This video is made in 2024, and the goal of the video is to help my current patient understand my current thought and treatment options for sleep apnea. So let's dive into it. There is a very likely chance that when if you're a current patient in my practice, that I notice some underdevelopment or signs of underdevelopment that's causing poor sleep. As a airway focused dentist, what I really look for is space. Typically, it's a tongue space or oral space. In other words, it's the oral space that houses the tongue. So if the oral space is narrow, high voltage, or deficient in what we call anterior posteriorly, meaning that your mid face, it's not forward enough, it essentially traps the lower jaw in, which brings the tongue back. And what's behind the tongue is the airway. So this is kind of like a prior example, a prior picture that I'd like to show is, if you look at this tongue, you can see that it just doesn't fit into the space. It's struggling to get into this, to go in between the two rows of teeth on top. That's why you see indentation. It doesn't fit into the lower jaw. So, if you can think of what this does to somebody when they sleep, it's poor sleep, because it's really taking up airway space. And I would suspect that this patient probably have snoring issues, poor sleep, and all of these is true. This person actually suffers from chronic fatigue syndrome, and is identified to have sleep component to it. So there are many things that we look for when you're sitting in the chair during the new patient exam or consult or hygiene exam that could be suspicious. And then what we talked about from a symptom standpoint, we want to confirm if there's any anatomical correlation to the symptoms that you're feeling. So oftentimes, if you haven't done this already, it could be this device, it could be any other device that maps out just different data when you sleep. Whether it's oxygen or position, heart rate, all these give us data of what's happening when you sleep. So what happens when you have a confirmed sleep apnea diagnosis? The gold standard in 2024, it's still consult your physician and have a discussion about CPAP. And at 2024, again, I don't want to deviate from that because it is the gold standard. Where I step in typically is, one, people don't want to have CPAP. Two, people tried CPAP and just absolutely can't handle it. And that's when we talk about different options, because if there's a confirmed diagnosis of sleep apnea, and if you do not wear the CPAP, then it's not helping you. So we're basically gonna deviate from the gold standard and find a solution that will at least help you. So I'm gonna talk about different options that we do in our office to help our patients. And yes, diagnosis is everything. So not only we want to have the data, we also want to a lot of times confirm there is anatomical restriction. So many times we take CT scans to find out where the joint position is, how big the airway space is, position of teeth. All these are information that will help us. Tool number one, again, not necessarily the best tool, is something called mandibular advancing device. MAD for short, which I'm going to call it. So MAD it doesn't make any changes to the anatomy. The goal of this device basically is to use the upper jaw or upper teeth as an anchor to hold the lower jaw forward. And what happens is when the lower jaw goes forward, it brings the tongue with it. And again, 90 to 95% of the sleep apnea issue is related to the tongue. So if we can get the tongue even a little bit out of the airway, that will help with data, help with symptoms. So what you see is these little wings are, again, pre-designed. We basically use this, they're actually, when we make it, they're actually different titration numbers, meaning that we'll position these devices sequentially. So we'll take a bite and we'll position the tabs sequentially in millimeters. So if I advance to 1 millimeter, 2 millimeter, 3 millimeter, 4 millimeters, there'll be different devices that we'll have our patients wear. And using the sleep watch, we're going to use the data to tell us what's the most optimal position to receive better sleep. So that's called a mandibular advancing device. Now, there are times we would use Invisalign to help. Now, Invisalign has its limitations. This tool is also not used for treating sleep apnea, and nobody's going to claim that. I mean, I'm not going to do that either. But remember, the problem is the space. So if we can actually use Invisalign as a tool to create more space for a tongue, we have found that there are some patients who actually got improvement from creating that extra space. So that's tool number 2, is Invisalign. Now, this is making permanent changes to the hard tissue, and we're going to talk about what's to follow that is the soft tissue change. So I see the treatment, aside from treatment number 1, where it makes no permanent changes, but just position the jaw when you wear the appliance. Option number 2, 3, 4 are going to be related to making permanent changes, basically in the form of different severity or invasiveness, if you want to call it. So Invisalign obviously is a fairly easy way to get more space, but the question is it enough to influence clinical data? That depends. So oftentimes I'll discuss with you. I'll look at your anatomy and basically make a guess, because a lot of times I know for sure? I don't. That's why we need the data to kind of support us. So we will move the teeth the way we like. That will create more space, and then we'll do a sleep study to see if there's an improvement, since we have a baseline data already. So Invisalign is option number 2. Pretty non-invasive form of treatment, but it also doesn't gain us a lot because, like I said, there are quite a bit of limitations of what Invisalign can do. Option number 3 is something called Vivos. Vivos actually is a device that's FDA approved to treat sleep apnea. I typically use this tool in conjunction with Invisalign. It basically is a removable adult palate expander that create, again, more space. There's quite a bit of commitment for Vivos. Vivos commitment is probably 14 to 16 hours a day. Typically, I have patients wear this device from sundown to the next morning. Being a removal device, the beauty of it is you can take it off to eat, brush, floss. Again, this goes the same with Invisalign. Just that Invisalign, you have to wear for at least 20 hours. Vivos, probably 14 hours, 16 hours. Still a lot, but you can probably skip wearing this during the day. So from, say, 4 o'clock, 5 o'clock at night, or in the afternoon, and wear it to next morning. Now, there is specific time and turning sequence and speed that I usually go over with our patients. And again, typically with expansion of Vivos, it is followed with Invisalign. This is an example of a patient who we treat with Vivos plus Invisalign. You can kind of tell before treatment, there is very, very narrow palate missing. During braces, they took out a bicuspid, and yet there's still crowding of teeth. So obviously, this patient is underdeveloped in all directions. The goal is to actually create more space. Now, there's also limitations to Vivos. We cannot create the space that's lost back or enough to put in another tooth in there with implants. Again, the goal is to create more space for the tongue. Try to help with airway by getting the tongue more space. And with the help of removable device, Vivos, plus Invisalign, we can actually see significant changes. So again, as you can see, the crowding is gone. The teeth are straight. We were able to create a little bit more space behind the canines, but not enough to house another tooth on either side. Okay, but interestingly, for this particular patient, AHI basically is a number that we look at when people have sleep study. Is how many times per hour do they have apnea. So his data went from sleep, the AHI of 11, down to 1 after Vivos plus Invisalign treatment. So I thought this is a win. He felt a lot better also. So great service for the patient, and unfortunately, this doesn't always happen with every single patient, but I know that creating more space is going to help. Fourth option is called MARPI, short for Mini Implant Assisted Rapid Palatal Expansion. The rapid palatal expansion is somewhat throwing things off a little bit. We do want to expand the palate, so the goal is to actually make space bigger surgically. So these are mini implants that were placed in the palate, and there's a schedule that we're going to turn this, and basically it stretches the palate out. Now with this option, it is surgical. It probably will provide the most benefit in terms of getting width, right? So the goal is to create more space, right? So this can get you a lot of space. It is also the most invasive, and that carries the highest risk. But these are all the things we talk about when it comes to risk and reward. So the reward is high, but there's also surgical risks that's associated with this. Surgical risk is low, though. I don't want to say this is not mandibular advancing. Actually, this is not maxillary surgery. It's not like cutting the jaw, but this is anchoring to stretch the jaw open. I like to use this picture as a guide. If you kind of think about this patient's bite, usually the analogy I like to give a lot when I talk to patients is the upper jaw is like the lid of the box, and the bottom jaw is the box. So if you look at this jaw, you would probably agree that the box is slightly too big for the lid. That's why it doesn't quite fit. And this is kind of how the bite is, right? So if the lid is too big, that doesn't fit the lower jaw, you really have a few options. One is you do surgery, or you take out teeth. Um, this the mouth discrepancy cannot be treated with Vivos or Invisalign. So for this particular patient who actually has sleep apnea, there's no other way to do it other than surgically change the shape of the lid. That's what we did. So we did some rapid expansion. Again, MARPI, mini implant assisted palate expansion for adults. Typically it's followed with Invisalign, or even during the process is followed by Invisalign. This is a progress photos, but this kind of just give you an idea of what we're trying to achieve here. You can kind of see now that the lid is just slightly bigger than the box now, without making any changes to the box. We still have to work out some of the bite issues, but that's what we're trying to do. Create the lid to be bigger, and have the lid fit over the box. And in doing so, that will influence the size of the palate, creating more space for the tongue, and also influence nasal cavity. So the beauty of having, if doing MARPI, is actually influence nasal cavity and nasal breathing. And the interesting comment I received from this patient during the treatment was he used to get nasal congestions all the time, and after MARPI, his nasal congestion is gone. Okay, so we spoke about 4 different options to treat sleep apnea, other than CPAP. And what we talked about with option 2, 3, or 4 is to influence the space, making changes to the hard tissue, so the palatal bone and also teeth. Typically, after we create that space, we would suggest patients to go through something called myofunction therapy. Think of the tongue as a muscle that we use every day. We use it from talking, to eating, to swallowing. When we create a bigger space for the tongue, if the tongue doesn't know how to function, or still functions the way that it used to, there is a good chance that it could actually bring enough force, or cause enough force from the outside to squeeze in the expanded palate. So what we like to do is have patients go through something called myofunction therapy. Is basically like physical therapy for the tongue. And after we do physical therapy, if there is a tongue tie, we would perform CO2 laser release of the tongue. Again, following the most current protocol is quite non-invasive, and usually along with myofunction therapy, and by creating an expanded space, we see, for the most part, most patients do improve and actually feel better. So I do also want to mention that sleep apnea, I don't want to call it the things that we do as a cure. Sleep apnea basically is on the spectrum, right? Sleep apnea, severe sleep apnea being the worst on the spectrum, or highest on the spectrum. But it's not a switch. It's not like we perform this, the sleep apnea will be gone. So every little things we do will help move the needle towards normal. So whether it's Invisalign, which is a smaller switch, you want to call it, versus like MARPI, it's a bigger switch. That will inch us closer to normal, Uh, the more we do it, like if we just do Invisalign and nothing else, you might move the needle a little bit. If you do MARPI plus myofunction therapy plus tongue release, uh, that will actually move the needle a lot, right? So all these are different things, different tools we have, and um, not every tool is appropriate for every single person. So it also depends on the symptoms, depending on the anatomy. Um, it could be finances. So there are many reasons why we suggest different treatment options for different people. So that's why having a conversation in the office will be very helpful. Okay, so I've said a lot, and again, if you have any questions, please reach out to me by email or call the office. I'll be happy to answer any questions for you. Thanks for watching. Thank you very much.